will be sharing the insight on personalized surfactant therapy for neonate, a matter of great relevance to both our scholarly discussion and the advancement of knowledge in this field. Dr. Alvaro, the floor is you.
I have two main objectives. For my presentation today. The first one is to describe the rationale and indication for surfactant treatment in preterm infants with RDS. And the second one is to discuss the indication for surfactant therapy in other respiratory conditions that may affect newborn babies. As you know, respiratory failure secondary to surfactant deficiency is a very well-known cause for morbidity and mortality in preterm infants. And since the development of surfactant therapy, this mortality and morbidity has significantly decreased in this population of preterm infants. Now, also, secondary surfactant deficiency, we know that contributes to acute respiratory morbidity in late preterm infants and term infants with meconial aspiration or pneumonia sepsis, and maybe also in some cases of pulmonary hemorrhage. And in this condition, surfactant therapy may also be beneficial. Now, although surfactant we know is the standard treatment for RDS, many practical questions remain about what RDS is and who should be treated and when. So this presentation will attempt to answer some of these questions on the basis of new clinical trials. So although surfactant has been widely used since the early 90s, several things have changed since that time. We know that smaller and more immature infants are surviving now and are being treated that previously were not treated. Second, we know that antenatal steroids have been used more widely, and most of these babies, most of these tiny babies are now born after being exposed to antenatal steroids. And also, most recent clinical trials have shown us that the management of RDS have significant change over the last 15, 20 years. So when we try to answer the question of who should be treated with surfactant therapy, we can say that most people now say that any preterm infant with significant respiratory failure due to RDS should receive surfactant therapy. Mm-hmm. The problem with this is that we still don't exactly know what significant respiratory failure is, and even the diagnosis of RDS sometimes is being questioned based on other conditions that can actually mimic the RDS. So here I'm going to show you a table that summarizes 4 major randomized clinical trials using surfactant therapy in small babies. As you can see here, in the Danish experience, the mean gestational age was about 27 weeks, and only 30% of these babies were treated with surfactant when they were initially started on nasal CPAP in the rhesus area. The control trial that randomized babies to receive prophylactic surfactant versus CPAP and rescue surfactant showed that only 38% of babies in the CPAP arm were treated with surfactant. The Vermont-Oxford trial that had babies between 26 and 29 weeks also showed that 45%, almost half the babies in the CPAP arm, did not receive surfactant. And more importantly, one of the largest trials, the support trials, that was published in 2010, that had a range of small babies going from 24 to 27 weeks that also were randomized at birth, showed that the babies that received early CPAP only received surfactant in about 67% of the time, although these babies were very, very small. So things get a bit complicated because, as I said before, the diagnosis of RDS is not clear-cut all the time, and there are other conditions that can actually present at birth that may mimic RDS or actually may contribute to the development of RDS. And these conditions are first pulmonary hypoplasia, that sometimes is present, sometimes severe, and that's a clear cut, but sometimes it's not that severe and it's mild, and is sometimes present in babies that are IUGR. And that may compromise the diagnosis of surfactant deficiency. Also, babies that are born and develop significant pulmonary hypertension and are requiring excessive amount of oxygen because of the poor pulmonary blood flow may actually compromise surfactant function and may actually make diagnosis of RDS more difficult. Babies that are also born that have surfactant deficiency, but on top of that, they may have a lung inflammation or pneumonia because they were exposed to chorioamnionitis before delivery. So those babies usually don't have a clear picture of RDS due to just surfactant deficiency. Also, babies that are born with excess amount of lung fluid in their lungs by the time they're born may actually compromise the diagnosis of RDS. And sometimes it's not just surfactant deficiency, but it's the fact that they have excess amount of fluid in the lungs, and sometimes by applying CPAP alone, that fluid can be clear, and surfactant may be enough in these babies. Also, there are some babies that need to be intubated, not because of surfactant deficiency, but because they have a poor respiratory drive, they develop apneas, and they need to be intubated. And all those babies also are exposed to early mechanical ventilation and may be experiencing injury from mechanical ventilation that also compromise the lungs and may make the diagnosis of RDS more difficult. So when we try to answer the question on when we should treat with surfactant therapy, the question that many of us asked 15, 20 years ago was, is it better to intubate and give surfactant as soon as possible, or stabilize the baby first on nasal CPAP and then give surfactant as a rescue only? And this question became important because most of the clinical trials in the 90s showed that prophylactic surfactant had better outcomes than when surfactant was used as a rescue. The problem with those trials in the 90s is that very few of those babies were exposed to early CPAP at the delivery. So when we realized that early CPAP was beneficial in all babies at the time of delivery, things changed. So in the between 2000 and 2010, there were several trials that compare prophylactic surfactant with rescue surfactant, but using very early CPAP in those babies that were not intubated right away. And those babies then received surfactant if they met a threshold for surfactant therapy. And those trials tried to answer the question of, well, is prophylactic surfactant still better than rescue? Now, there are pros and cons for prophylactic surfactant. The pros is that any ventilation with RDS can cause lung injury. So if you actually give the surfactant very early and try to give it even before you expose the baby to positive pressure ventilation, you may actually improve the lung outcome. The contraindication or the cons of this approach is that you're going to be treating a lot of babies with surfactant without RDS. And that means that you're going to intubate and expose these babies to mechanical ventilation and surfactant therapy, even though many of these babies will never develop RDS. Now, after all these trials, I think the clear answer from all those trials was summarized by Rojas and Reyes in a meta-analysis producing Cochrane database 2012. And they concluded that recent large trials reflecting current practice using antenatal steroids and routine stabilization on CPAP demonstrate less risk of chronic lung disease or death with early stabilization on CPAP with selective surfactant administration to infants requiring intubation. So as I said, at least in babies over 25 weeks and above, there is no benefit from intubating all these babies to give prophylactic surfactant. All those babies now, if they're stable and breathing after birth, they should be started on CPAP right away and should be given surfactant if they meet a threshold that we are going to discuss. And that threshold may vary also. Okay. Now, having said this, many of these babies, most of these trials did not include babies under 25 weeks. So we still don't have a clear indication on what to do on babies that are less than 25 weeks because we don't have the information on those babies. So I can tell you what we do in those tiny babies under 25 weeks. But again, that's not going to be supported by the literature because we don't have enough information on those tiny babies. So having said all this, there's still some questions that needs to be answered, and we don't have a clear picture on these questions. The first one is who are the CPAP treated preterm infants with RDS that will actually benefit from surfactant? So what's the threshold to decide that CPAP has failed? So what is CPAP failure? And the third question is how do we define RDS severity? So these questions need to be answered with more clinical trials, and hopefully we'll have an answer, more clear answer in the next few years. Very good. When we try to decide if it's better to give surfactant early, not prophylactic, but again, babies on CPAP, how long we should wait until we give the surfactant. Most studies have compared giving surfactant in the first 2 hours after being placed on CPAP versus a delayed surfactant that were given after 2 hours of age. Now, most of the studies have shown that early surfactant within the first 2 hours was associated with a significant decrease in mortality, was also associated with a significant decrease in BPD at 36 weeks, significant decrease in BPD or death at 36 weeks, and also have shown that when surfactant is given in the first 2 hours, there is a reduction in the risk of air leak. The studies have not shown an increased risk of pulmonary hemorrhage, and they did not show any increased risk for IVH. So the next question that we are trying to answer is how should surfactant be given? We know that initially surfactant was given after babies were intubated and were exposed to mechanical ventilation. Then a new method of giving surfactant was we call ensure. Babies that were breathing stable on CPAP that require surfactant, then were intubated just to give surfactant, received surfactant, and then were extubated soon after. And a new method to give surfactant that has been developed over the last 20 years or so is what we call less invasive surfactant administration, or LISA. Now, there are two ways of giving minimally invasive surfactant. One is what we call LISA, which uses a soft catheter and McGill forceps to be able to guide that soft catheter into the airway. The other technique is what we call MIST, that uses a stiffer catheter, usually an angiocath or a special catheter that is stiffer, that do not need McGill forceps for its introduction. That's called MIST. But regardless, it's a method in which you do not use endotracheal tube. You try to prevent exposing the babies to positive pressure ventilation. You're allowing the baby to breathe in and out where you are giving the surfactant. And these babies are usually kept on nasal CPAP throughout the procedure. So when this new technique was compared with the ensure, And then studies have shown first that LISA or mist was associated with less need for mechanical ventilation. It was also shown that decreased the risk of BPD at 36 weeks in survivor, and also reduced death or BPD at 36 weeks. And there were no differences in other outcomes like respiratory morbidity, neural outcome, developmental outcome at 2 years of age in infants, comparing both meds insured versus LISA or med. Now, moving on to indication for surfactant in other conditions than RDS, cases of respiratory failure in late preterm infants and term infants due to meconium aspiration syndrome. We know that these babies sometimes develop severe respiratory failure and persistent pulmonary hypertension. That can be complicated by surfactant inactivation produced by the meconium and the inflammation. There hasn't been too many studies comparing assessing the usefulness of surfactant in meconium aspiration syndrome, but the few studies that have been published have shown that surfactant replacement in infants with severe meconium aspiration improve oxygenation and reduces the need for extracorporeal membrane oxygenation or ECMO. I guess the key word here is severe, and only infants that need to be intubated and ventilated for meconium aspiration with high oxygen requirement may actually benefit from early and sometimes repetitive doses of surfactant. Those trials have shown that surfactant does not reduce mortality or decrease the frequency of leaks. And also, this study has shown that surfactant may actually shorten the duration of ECMO. Okay, what about surfactant therapy for babies that are born with pneumonia? Well, it is well known that surfactant inactivation may be associated with pneumonia, and this surfactant inactivation and dysfunction sometimes can contribute to the respiratory failure that we see during the course of neonatal pneumonia. There are not many studies looking at the effectiveness of surfactant during neonatal pneumonia. Overall, we can say that gas exchange does seem to be improved with surfactant treatment, although transiently following surfactant administration in this group of patients with pneumonia. So in summary, we can say that surfactant may improve oxygenation and reduce the need for ECMO, especially in those infants with severe respiratory failure. Because of the lack of RCTs in this area, routine surfactant therapy cannot be recommended. And again, because there is no evidence that surfactant therapy actually helps to improve any relevant clinical outcomes in neonatal pneumonia, I would say that individualized approach is recommended for infants with this condition. Okay, now what about the use of surfactant with pulmonary hemorrhage? We know that blood may inhibit surfactant function, and surfactant replacement in severe cases of pulmonary hemorrhage can be beneficial. However, only a few retrospective and observational reports have documented the benefits of such therapy in pulmonary hemorrhage. And the magnitude of the benefits really remains to be established by other trials. We can say that only 2 small observational studies have suggested that administering surfactant after pulmonary hemorrhage may actually improve oxygenation index in these infants. So again, to summarize, surfactant therapy may improve oxygenation, but we don't have enough information to make this a strong. Okay, what about surfactant therapy in babies with congenital diaphragmatic hernia? Now, although congenital diaphragmatic hernia may be associated with surfactant deficiency, a large series of infants with congenital diaphragmatic hernia treated with surfactant not only did not improve outcome, but there was an increased need for ECMO, and also the incidence of chronic gland disease and mortality rate were increased with surfactant administration. So therefore, at this particular moment, surfactant therapy is not recommended for infants with congenital diaphragmatic hernia. So now I'm going to give you a summary of the indication for surfactant therapy based again on most of the clinical trials that have been done until now. And this is something that we use in our unit. Some of these recommendations may not be shared by other units. This is what we do. I guess some of the things that we discuss are not very clear in terms of which baby should receive and should not receive surfactant. So the first one is that any preterm infant less than 30 weeks that requires intubation for stabilization should receive surfactant. And this is a very, very strong evidence. And I don't think anybody will argue with this. The second recommendation, which is also very, very strong, is that nasal CPAP or NIPPV, ideally synchronized NIPPV, should be started from birth in all babies under 30 weeks gestational age who do not need intubation for stabilization should receive surfactant. Again, this is a very strong evidence, and I think it's shared for most units in the world. The third recommendation is that any preterm infant with worsening respiratory condition, despite using a CPAP, a nasal CPAP of 6 or higher, and requiring an FiO2 higher than 30% to maintain a preductal SATs over 90%, should also receive surfactant. And this is actually also a very strong evidence for that. The next recommendation is not as strong. We can say that any preterm infant with RDS on nasal CPAP of 6 or higher require an FiO2 of 25% or higher to maintain preductal SATs at 90% and have a lung ultrasound that suggests surfactant need should also receive surfactant. As you can see here, the threshold is a bit lower. It's 25% instead of 30, but you're adding the evidence from a lung ultrasound to detect or make diagnosis of surfactant deficiency. And I would say the evidence for this recommendation is moderate. The next one is also a strong recommendation. Babies with RDS needing treatment should be given an animal-derived surfactant preparation that has been shown to be much more effective than synthetic surfactant. And again, this is strong evidence. And there is no significant differences between different natural surfactants. The next recommendation is related to the way of administering surfactant. LISA or MIST is the preferred method for surfactant administration for spontaneously breathing babies on nasal CPAP. And this is also a very strong recommendation. We didn't discuss this, but there are a few studies that have tried to use laryngeal mask to deliver surfactant. Those studies were done in bigger babies and have shown to be effective. So we can recommend that you can use laryngeal mask to give surfactant in more mature infants if they're over 1 kilo. And this is a moderate evidence. In terms of how many doses of surfactant you need to be given, studies have shown that repeated doses of surfactant should be provided to infants only when there is evidence of ongoing moderate to severe RDS, and other problems have been excluded, like PDA, for example, and this is also a strong evidence. Surfactant administration could be beneficial in severe pulmonary hemorrhage and meconium aspiration syndrome. Again, the evidence here is moderate. Infants with neonatal pneumonia should receive surfactant. And again, these are conditions that I usually use surfactant in baby with pneumonia. The first one, the baby has to be ventilated, requiring an FiO2 of more than 60% and show signs of poor lung compliance. Second is you have to have signs, clinical or radiologic evidence of surfactant inactivation. Babies that are failing to respond to supportive care and antibiotics for pneumonia could also be benefiting from surfactant therapy. Again, the evidence for all this is very weak. Very few trials have shown support for this recommendation. So in summary, many practical questions remained about what RDS is and who should be treated and when. Clinical data now supports an initial use of continuous positive airway pressure to stabilize most infants before treatment. The optimal way to treat an infant is still under intense investigation. The best treatment option for an infant ultimately depends on gestational age, the clinical status, and also the experience of the clinician or the unit where the baby is being treated. And finally, the difference in surfactants are minor, given the low rate of complication with any surfactant treatment. So the advantage of one brand over the other is minimal. As long as they're a natural surfactant, those are the surfactants usually we recommend to use. Thank you very much, and I'll be available for questions. Thank you.
Okay, thank you very much, Professor Vieira, and for this very informative lecture. And actually, it will excite many questions. And actually, let me just have one question, because the word personalized used many times now with the introduction of artificial intelligence. So how we make the use of surfactant based on some criteria using artificial intelligence to be directed for a single baby different from the other. For example, having lung ultrasound, having the baby receive steroid or not, baby gestational age, how it looks at the after birth, and then after 2 hours, what level of CPAP he is on, and all of this. So do you think that AI can be helpful in this respect, in this aspect, so we can move in this area or not?
Hi, I'm available right now. I tried to open up my video, but it says that the host has been disabled. So if somebody can allow me to show my video, that would be great. Can you see me? No. I can't unlock my video. It says it is disabled by the host.
Who is disabled?
Yes, we can hear you.
Okay, I guess you can't see me, but I can hear you.
Yeah.
So your question is a very good question. I think definitely AI should be able to help us integrating different algorithms. However, there are still a lot of things that we don't know, especially what's the ideal threshold for treating a baby with surfactant. And the reason for that is it's not a clear cut, because it depends a lot on the experience of the clinician, the experience of the NICU where the baby is being treated. If you are very comfortable with intubation, you are very comfortable with CPAP, definitely can maybe wait a bit longer. If you're a unit that are not very familiar with CPAP, you are not having a good CPAP outcomes, and you're good with intubation, you may be better off intubating those babies sooner. If you have somebody that don't know how to intubate or is going to cause more problems intubating, you may have to wait a bit longer. So there are a lot of variables that will influence at what threshold a baby needs to be treated with surfactant. So I don't think AI will solve all those problems yet. Eventually it might, with more trials.
Okay, thank you. There is some question in chat box. So what is the dosage of surfactant for meconium aspiration if it can be used?
Yeah, the dose that we use for meconium aspiration is the same as the dose that we use for RDS in preterm infants. And again, it depends on the type of surfactant you're using. Here in Canada, we use Bless that has a lower concentration of surfactant than Curocell, for example. But the dose should be the same as RDS. And again, remember when you're going to give surfactant for meconium, the meconium aspiration has to be severe. Don't start giving surfactant to any baby with just any signs of meconium aspiration because you're going to do more harm than good. So we're talking about only severe cases of meconium aspiration, babies that are intubated and require very high oxygen requirements.
Again, another question about the best technique to administer the surfactant. If the needs and if need some additive like analgesia for it or something.
Yeah, that's a very good question. I guess we know that when you are intubating a baby to give surfactant, most of the center will give a full sedation, including narcotics, atropine, and succinylcholine. However, when you're using a mist or Lisa, you want those babies to breathe. So the way we deal with that is we use a very small dose of fentanyl, only 1/3 of the total dose that we use for regular intubation. And we use just a small dose of atropine. And of course, we don't use succinylcholine. And we find that most babies will be okay with that and will not go apneic. But every now and then we get a baby that responds very strong to even a very small dose of fentanyl, and unfortunately have to be intubated for that. Yeah.
Again, what about the using of surfactant in ARDS? I mean, older neonate who are a few weeks old.
Well, I don't think I will comment on that because I don't have a lot of experience with older babies. So I can give you my personal opinion, but I will leave that for people that have more experience than me because I don't deal with older babies. So unless you're talking about chronic lung disease, something else, but I won't be able to comment on ARDS in bigger babies.
Okay. And any other questions? So can Dr. Wafa, unmute yourself. Yes.
Yeah. Thank you for your awesome presentation. Thank you very much. But I have a question about the subject itself. I thought it is personalization of surfactant administration for each baby, not one dose fitting all. And I'm expecting, as Dr. Rida said, the role of AI and machine learning. And I have a question before even the presentation. What type of AI you can use if you want to use an AI as a choice to deal with personalization of administration? Do you use the AI with ultrasound, AI with echo, AI with hemodynamic instability? Do you have certain type of software and learning machine to deal with such cases, specific neonates? Thank you.
Yeah. Originally, the topic of my presentation was going to be precise administration of surfactant, and I guess we are going eventually to have that information to individualize the treatment of surfactant for each particular patient. And there's a lot of research going on right now in trying to find out exactly what's the degree of surfactant deficiency in any baby at the time of delivery or just before delivery by measuring surfactant pools, either in the stomach, on the tracheal aspirates, and all those are still under investigation. That's what I didn't want to include all those studies, because right now we are still waiting for information from those studies. Eventually, when those studies have proved that it's useful, then we're going to try to measure exactly how much surfactant each particular baby has at the time of delivery. And that will help us more precisely to know exactly which baby needs to be treated with surfactant or not. So we are not just going to base our surfactant decision-making on the level of CPAP or FiO2, but we're going to base it on actually the amount of surfactant every patient has at the time of delivery. And that definitely will help us to be more selective in our patients. So I don't know if that's the question, but because of the wanting to do this presentation more clinically, I didn't want to include all those studies that are still not used in clinical practice.
Dr. Rafael and Dr. Dabassioni, there was a lecture by Mark Attar 30 minutes, 2 hours ago about artificial intelligence in neonatal care.
Oh, that's
so this was the title of his presentation. And he's one of the most specialized person in the UK in AI, in neonatal care. So,
okay.
But
okay.
AI in neonatal care, yes. I just want to ask Dr. Alvaro one question, if available, Dr.
Yeah, okay. Dr. Azza, go ahead.
No, this is just a practical question. If, for example, a neonate that needs the immunosurfactant to be repeated, each time you use the LISA, or if he, for example, needs the second or third dose at that time, you will decide that this patient, this baby may need the invasive type.
No, yeah, if the baby is still on nasal CPAP, and the only reason to repeat the dose surfactant is because the FiO2 has gone up, and there is no any other reason for intubation, you can give the second dose as a LISA also. There is no contraindication to repeat LISA or MIST. But the problem is many of those babies, when they need a second, third dose, is because they're getting significantly sicker, and that's maybe why they require a second dose, and those babies may need to actually to be intubated and ventilated.
Yes, okay. And the time that you indicated the surfactant for meconium aspiration, it was the severe type of meconium aspiration. What about the pneumonia? It should be also severe type. It's also.
Yeah, with pneumonia is the one condition that we have the least amount of information. Is extremely controversial because we don't have enough information from trials. What I put in my slide was the 3 conditions that we usually use in our unit to give surfactant in babies with pneumonia. In general, again, the condition has to be severe enough. The baby needs to be intubated. The baby needs to be on high oxygen concentration. You need to prove that if you want to repeat the surfactant, that the first dose actually improve gas exchange. But remember that right now we don't have any significant information saying that actually giving surfactant will actually improve outcome in these babies. So it's a clinical decision that you have to make according to the patient you have in front of you. I can't give you a clear answer, unfortunately.
Okay, thank you.
Okay. Finally, I thank you very much, Prof. Alvaro. And actually, further question can be directed to his email if he doesn't mind. And we can put his email in the chat box. So if any question would be there. Thank you very much. I appreciate it. Thank you.
Dr. Yasser.
That's it, Dr.
Yasser?
Yes, I'm ready. Yeah.
Okay.
Dr. Yasser will start now. We have a pleasure to introduce Dr. Yasser. Can you give me just 1 minute to introduce you, Dr. Yasser?
Yeah, go ahead, please.
Dr. Yasser is a professor of pediatrics at the University of Manitoba, a staff neonatologist, a registered echocardiologist, and a researcher at the Children's Hospital Research Institute